Thank you for joining us for this Epilepsy and Prose webinar. If this is your first time attending one of our webinars, my name is Shannon Bennett. Christy Collins and I are your hosts with the MCM Network. Joining us today, we have Dr. Jena Krueger from Corewell Health Helen DeVos Children's Hospital. Dr. Krueger is a board-certified pediatric neurologist specializing in child neurology and epilepsy. She earned her medical degree from Michigan State University College of Human Medicine in East Lansing. She completed her pediatric and pediatrics neurology residencies and her clinical neurophysiology fellowship at Ann and Robert H. Lurie Children's Hospital in Chicago, Northwestern University. She also happens to be a rare disease mom herself with an adorable little boy named Sebastian, or who we all call Bash, who has Noonan syndrome. I'm fairly partial to Dr. Krueger, mostly because she's Kenzie's neurologist and who we affectionately refer to as the Team Kenzie quarterback because of how amazing she is. So with that, I'll go ahead and hand it over to you, Dr. Krueger.
Thank you. It feels weird to be Dr. Krueger. I'm usually
It does.
just
It does feel weird to call you that, but
I am just Jena in general.
Yeah, I know.
Okay. I did my best. I was muting everything I can find on my phone. I think I turned the volume off the pager. Otherwise, that thing just gets through all filters. You cannot turn off a pager on your phone. But so thank you for the introduction. So like Shannon said, I am a pediatric neurologist. The neurophys fellowship was actually a fellowship in epilepsy. So doing EEGs and epilepsy care for children with complex needs. I do a little bit of epilepsy still, but I spend a lot of my time now in research with kids with muscle diseases and gene therapy and some really cool gene editing therapies. And then still have some of my primary epilepsy patients as a pediatric neurologist. So today I'm going to talk about epilepsy in prose and MCAP. And as a complete disclaimer, I am not an expert in prose or MCAP or the PIKE3 mutation. And my son has a PTPN11 mutation. And as I always tell families when they have a genetic diagnosis or a genetic mutation, and it's rare and you're in this world of rare disease, I feel like parents are always the expert. So when I go to my son's specialist, I take the guidelines and I say, this is what we're going to do. The first time I met Shannon, she literally handed me an MCAP brochure that is pinned to my home office bulletin board. Now I still have it there to say, have you ever heard of MCAP? Here, this is what it is. And you shouldn't be afraid of that because we appreciate it. And if your doctor is offended by it, maybe that's not the right person for you to see. So I'm an expert in epilepsy. I have been through lots of seizure treatments and and I've been at my current job for about 9 years. So let's jump in. I do research. So anytime you have a presentation by a physician or a researcher, it's super important to listen to their disclosures. So if they're getting money from someone, they're going to be even subconsciously influenced by them. I do not get any money. The first section there, I do clinical trials. So these are all companies that sponsor clinical trial. They give money to the hospital to support the actual trial. I do not personally get any money. And then I did some brief consulting work for the company Astellas. So I was on the safety monitoring board. So when you have a clinical trial, all of the data goes to this impartial group of people that aren't related to the trial at all, they aren't affiliated with any of the hospitals, and they monitor all the data. So I did a data safety monitoring board for a gene therapy product, and that's not going on anymore. So I don't have any disclosures. I don't intend to, but there may be something that pops up in the world of off-label use. A lot of what we do in pediatrics is off-label use. So there may be things I mention not on purpose, and I'll try to illustrate if I am, but there may be things that come up in conversation that might be off-label for pediatrics. Okay, so my goal today is to just start at the very basics. So PIKE3 mutations can have a wide range of epilepsy syndromes depending on kind of where that epilepsy is coming from. And so I want to start at the very, very beginning and talk about what is a seizure, what is epilepsy, and kind of talk about the different things that help us decide and help us make good decisions on medications and treatments and when you don't need medications or treatments. So starting at the very basic, a seizure. So not all seizures are epilepsy. Anyone's brain could have a seizure. And I should say, if I'm talking too fast, because I'm from rural northern Michigan originally, and we talk real fast. If I'm talking too fast, please jump in. If I'm not making sense, I was on call last night, so if I'm not making sense, it seems very clear in my head. But if I don't make sense, jump in, speak up, throw up your hand, interrupt. This is really a session that I hope is very tailored to what you want or need to get out of it. So if there's questions, please jump in. I'm not offended. I tried to keep it so there at least be time for questions at the end, but jump in the middle. If we take a tangent, that's always a fun journey too. Okay, so seizure. A seizure is just abnormal electricity in the brain. Your brain is made of tiny little cells called neurons. And neurons are these little, at their very, very basic, it's a little head and a little string. And electricity runs through the neurons from neuron to neuron. And that's how we do things in our brain. Each neuron will either increase that pulse of electricity or turn off that pulse of electricity. And that usually is due to the cells that go in and out of your brain cells. So the electrolytes. So at its very, very basic level, sodium and calcium and potassium at their very, very building blocks will go in and out of your brain cells. And they have different electrical charges. So that forces electricity to kind of pulse through your brain and go from brain cell to brain cell. So when you have a seizure, you have a little burst of electricity. And wherever that is in your brain is how your body responds to that. So the classic seizure that you might have seen on TV or in another person or even in your own child with that full generalized stiffening and shaking, what we call like a generalized seizure can be what you see for a seizure, or you might have a focal seizure. So a focal seizure depends on will look like wherever it is affecting the brain. So if you have a focal seizure here, you're going to see movement on the right side of the brain because that's the motor strip, and the opposite side of the brain controls the opposite side of the body. If I have a seizure in the back of my brain, especially towards where the two, like the parietal lobe and the occipital lobe, those two parts of the brain and where they merge, if you have a seizure right in that area, you might see vomiting. I have kids that have seizures in the very, very back of their brain, and it stimulates their vision because that's your vision area. And it's not formed things like people or things that are very, very clear. You just kind of see vague visual symptoms. Sometimes it's shapes or colors or it's kind of like a recollection. You can have other things too. So temporal lobe seizures are kind of that lobe right here deep to your ears. The temporal lobe is a really common place for seizures, and they can present with weird things like this feeling like you're on a roller coaster and you're that feeling of your stomach like rising up, or weird smells or weird tastes. There's lots of different things that seizures can look like, and it really depends on where that seizure starts in the brain. Now, epilepsy is when you've had two or more seizures and you have a risk to have another one. So in children, we can actually say you've had one seizure, but if you have something in your workup, like an abnormal EEG or an abnormal MRI, or even a very specific seizure syndrome, then we would say that's epilepsy. So all seizures are abnormal electricity. Epilepsy is composed of seizures, but not all seizures are epilepsy. And when we get to the point of epilepsy, that's when we start medications and things to prevent seizures from happening. A lot of on the very bottom of the screen are going to be where I found my information and where I recommend that you go for your information. The Epilepsy Foundation, which actually has the website epilepsy.com, is a phenomenal resource for epilepsy. It has text if you're a millennial like me. It has videos if you're younger than me and you want to just watch. And it is written by the experts in the field. And so it has really, really great information across the board about really anything that you need to know about epilepsy, and a lot of resources to connect you if you want to talk to somebody or you need medication help or anything like that. It's a great national resource. Okay, so how do we diagnose epilepsy? The most important things we look at the history. So what you're telling us, what you saw, or how many times it's happened. So when we're talking about seizures, we're talking about what you saw. We're going to ask very, very specific questions. We're going to want to know, what were they doing right before? What did it look like when it started? We're going to want to know, how did it progress? One of my favorite questions is, how did you know it was over? So one of the really common ways you know a seizure is over is because the patient will go, they take a big deep breath, and the lights turned off right when I took a breath for effect. So that was impressive, not on purpose. I want to know, how frequently are those events happening? Are they happening every day? Are they happening a couple times an hour? Do they happen in the morning? Do they happen at night? Do they happen after a long day in the sun? We want to know, is there anything that provokes them? So do they only happen with flashing lights? Do they only happen if they stay up really late? Do they happen when you're driving down the road? Anything that seems like it's correlating, what we want to know. Want to know if there's a family history. With kids with PROS or MCAP or kids with a type 3 mutation, they're going to have their own set of risk factors. So family history isn't as important, but we still want to know about it. And we want to know medical history. So we want to know, what medications are you taking? Did you start something that could have provoked a seizure? We could take that medicine away and then not have seizures anymore. We want to know if you've ever had anything that affected the brain or any other syndromes that we know could increase your risk of this being a seizure. It's all about taking a history to figure out, was this a seizure and what are my next steps? You'll get an exam, depending on your PCP or if you're in the ER or you're at the neurologist. As a neurologist, we do a very in-depth exam to see if there's anything on that exam that gives me a clue that the MRI could be different. So we're going to talk on one of the coming slides about what MRI pictures we see in type 3 mutations. And the biggest thing I look for in patients with other overgrowth is to look to see if the two sides are symmetric. So is my strength on this side the same as my strength on this side? Are my reflexes on this side the same as my reflexes on this side? Do the 12 nerves that control your face and your talking and your swallowing, really everything in your head, do those all work? Are my eyes doing exactly what I expect them to? Can they follow? Do the pupils do normal things? We're all just looking for clues to tell me that something in the neurologic system, be it the brain, be it the spinal cord, or the nerves that go communicate with the muscles, to give me a clue of what could be causing a seizure. And then the third step is imaging and tests. If you get referred to a neurologist, you're going to start with a history and an exam. And if the history is concerning enough when you're referred to neurology, you'll probably start with an EEG. An EEG, and I have some slides on what an EEG looks like and kind of what you see out of an EEG, but an EEG may be short. So in my clinic, usually we get like a 30-minute EEG. So you come in, you get all these little leads hooked up to your head. I tell the kids it looks like a little Barbie cereal bowl. And they use something kind of like toothpaste to stick it to your head. Then they wrap it up in gauze like a mummy, and we leave it running for 30 minutes. And then when you're done, you just take a nice warm soapy washcloth to wipe it off. And then the neurologist will come and look at that report. And we look at them right after they happen before we see you in clinic. So we have, the history, we have our exam, and we already have an EEG. Sometimes I can't determine because an EEG is a snapshot in time. And sometimes we need to do a longer EEG. So you'd be admitted to what we call an epilepsy monitoring unit or an EMU or whatever individual hospitals call them, different things. And you come in the morning or early afternoon and you stay hooked up for about 20 hours. You stay hooked up all day, all night. So we can see what your EEG looks like when you're awake, when you're drowsy, when you're asleep, when we wake you up a little early. We do tests like have them hyperventilate and do breathing that kind of like makes them blow off a lot of their carbon dioxide and have a lower kind of threshold for seizures. We also do the flashing lights. There's a very specific types of epilepsy that respond to flashing lights. And so when we flash the lights, we start at a certain frequency, and it's a very specific certain frequency that we cycle through to see if your brain changes when you're seeing those flashing lights. Even if your eyes are closed, you still see that frequency of light. So even in like my babies, who close their eyes and they don't want to be seen, you can see the back of the brain, that occipital lobe, the vision center, responding to those flashing lights, sometimes in a very normal way or sometimes in an abnormal way. And kids too, my teenagers, even if they close their eyes, you can see the brain responding. Sometimes it's normal, sometimes it gives you a clue that they're sensitive or what we call photosensitive. If you're photosensitive, sometimes we'll prescribe you a very dark pair of glasses. It's a very specific coating called Z1 lenses, and that blocks those specific frequency of light or that threshold of light, so it doesn't provoke seizures. And then the last EEG, I kind of hesitate to even mention because it's not my favorite because I'm a pediatric provider and they're very difficult, but it's called an ambulatory EEG. And that is when we send a company to your home and they hook up the EEG and they set up a camera and you do the EEG at home or even going to school and things like that. The reason I don't love them in children is because when you're in the hospital or you're in the EEG lab, the EEG techs are constantly fixing those leads. Those leads are just stuck in that like gummy kind of toothpaste-like substance, and they slide and they move or they pull off a little bit and then they don't pick up well. Because EEG leads are just reading the electricity from the brain, but you also have electricity in your muscles. So you get a lot of artifact, especially here when you're chewing. One time I saw a nurse give all the patients in the EMU gum when he was doing his rounds, and it was like the worst EEGs forever. And to go and take away everyone's gum because that chewing artifact masked all our brain activity. Um, so typically you start with like a routine short EEG, and then if you need to, you move on to an overnight EEG. Sometimes we even do multi-day EEGs in the hospital with, 4 or 5 days if we really have a specific movement or behavior we want to capture. And that way we can definitively tell at that moment in time, that movement showed abnormal electricity on the brain, so we know it's a seizure. Okay. So, why are your kids at a higher risk of seizure? And the biggest risk factor is that it's often associated with an abnormal brain. So, abnormal structure of the brain. Our brain is a very, very regular routine thing. As it's growing and developing, it grows in a very specific way. The cells move out. There's like 6 distinct layers of the brain, and all the cells migrate in this very, very particular patterned way. Sometimes they don't. And that's when you see seizures, because when the cells are migrating in a different way or moving in a different way to form that brain in those very, very early stages, or you have an area that's abnormal, whether it's from when they're formed, or if it could be from a little injury, if there's a bleed or a tumor, things like that, that damages the brain. And even when it heals, you have a little scar called gliosis. That's the medical word for scar in the brain. The brain doesn't like things that are irregular, and so it can often leave a risk of seizures. So these are kind of like 3 big patterns of abnormal MRI that we can see in the PIKE3 mutations. So that, I don't know. I hope you can see my cursor. Can you see the arrow as I move it around okay, cool. So this first one is something called hemimegalencephaly. So hemimeg is the short term for it. Hemimeg is when one half of the brain is bigger than the other. So this line right here is actually the line between the 2 halves of the brain. So that's actually a space until you get down to like the closer to like the middle of the brain. And you can see on this MRI that this half of the brain is just growing at a faster rate. And this is a particular pattern that we see in PIKE3 mutations or in other syndromes. But this half of the brain that is growing bigger, those cells have abnormalities in them, and then they can provoke seizures. So you'll see seizures from half of the brain. There's a lot of ways that we approach hemimegalencephaly, hemimeg. The first one we typically start with our traditional seizure meds to see if we can calm down this area of the brain to have more routine or typical electrical activity. Sometimes it's surgery. Sometimes they'll go through and they'll disconnect the connections between the 2 halves of the brain, and so this side of the brain can have seizures, but it won't spread to the other side of the brain that's unaffected. And because kids have such amazing ability to adapt and what's called plasticity, where the brain has the ability to kind of shift and change. If one part of the brain isn't working well, the other side of the brain can kind of take over and do some of those activities. Kids who have a disconnect procedure can do very, very well. Um, and then there's some new literature, there's some new things coming out with hemi-meg about using medications that can help do some immunosuppression. Some thought that maybe there's some influence from, inflammation, or as you move through these pathways in the brain and our body, the mTOR, overgrowth pathways. So there's a lot of new things that are happening as we move forward and focus on like kind of getting down to the cellular level. The other way we treat it, we'll talk about some of the treatments for epilepsy that we can do with some things that are not medications. But the next one is a focal cortical dysplasia. So cortical just refers to cortex. That's the layers of the brain. So all of this is just regular old brain. Dysplasia means abnormal cells, and focal just means in one place. So if you look at this MRI back here on the kind of lower left, or kind of at the 7 p.m. region, if you're thinking about a clock, you can just tell there's like a little triangle here where it's a little bit lighter and it doesn't have those folds and like grooves that you see in the other parts of the brain. That's a focal cortical dysplasia. And that tells me that in that area of the brain, the cells are different, and that can be provoking to seizures. And then the other area is talking about dysplastic megalencephaly. So dysplastic, abnormal cells, and megalencephaly is just talking about large brain. And so there's a lot of different types of megalencephaly, but what it's telling you is that there's difference in those cells. As the brain gets bigger and grows, it has abnormalities in those cells. And so sometimes you can see things like polymicrogyria. So poly means many, micro, small. So instead of these, the bumps of the brain, which are called gyri, instead of having the normal size and shape, there's many more of them. So they're smaller. You can have macrogyria, you can have big, you can have pachygyria, so they're not as indented. And really, all that tells me is the individual names or individual structure or the individual changes in the brain aren't the important part. The important part is that at some point, the brain developed in a different way. And so that brain, when it's not in its regular pattern, is annoying. And that's what causes the seizures. I think another important thing to think about in seizures and type 3 mutations is that if you look on this bottom row, M through P, these on this scan, on N, this darker shape in the middle, this is actually a space in the middle of the brain. This is a ventricle. This is the space where the fluid is. And then on these ones, because the picture is taken in a different way, they're white. So these almost looks like an X. Those are white spaces, but it's the same space in a different view. And sometimes in, especially in MCAP, you see those ventricles get bigger. And those ventricles often are getting bigger because there's too much fluid in that space, whether it can't flow from the brain down your spine and have a constant flow between the brain and the spine and all the way around. And it has a kind of a blockage, almost like a dam where the water develops behind it. Sometimes that's why you see these bigger ventricles. Sometimes you see just those ventricles getting bigger and the brain kind of getting a little bit smaller as it grows up. Sometimes those cells shrink down. The medical word is atrophy. And that's important because if you start seeing seizures from those, that is when you would need something that helps prevent that blockage of fluid. So sometimes kids get surgeries or things like that. And if you have a shunt or you've had a seizure, a procedure or that process done, sometimes seizures, when they come through, are telling you that there's a problem there. So it's kind of a warning sign. Okay. So EEG, as a neurologist, obviously the EEG is my favorite part. I love this picture. I stole it from the Epilepsy Foundation a long time ago. But these little, I don't know why I'm pointing with my hands. That's not going to help. Let me try this. So each of these little circles is a cup, and it attaches to the head with that gummy toothpaste-like stuff. And then that little white square is just a piece of gauze. It's just how you stick those to the head. If you needed to, you could just pull them right off. I wouldn't because it pulls the hair and it's uncomfortable. But if you just take a warm salty washcloth, it wipes all the leads right off. You will need to go home and take like 1 or 2 tubbies because that gummy stuff stays in the hair. You have to kind of wash the hair and scrub it out. Each of these leads that are on the head measures a point of electricity. And then we string them together into different lines. So the slides that I'm going to show you in a couple, these next slides are pictures of EEGs. This is one of the more common things that we look at, and they represent 4 lines across the head. And so they're lined from here to here and here to here. And I'm just looking to see if that electricity changes and causes something that's unexpected. So you get used to reading EEGs and you know what you should be looking for and based on age. And whenever something stands out, you have to decide, is that abnormal? Is that a normal thing for a kid? Are they sleeping? Or is that a sign that that moment, or that probably usually about 0.2 of a second, is abnormal electricity? And if there's abnormal electricity, that's called an interictal epileptiform discharge. So when you're reading your EEG report, you might see that described as a spike or a sharp. And that itself is not a seizure, but a spike or a sharp or an IED or an interictal epileptiform discharge tells me that for that moment where you saw that discharge anywhere between 0.2 to 1 second, the electricity of the brain in that location was a little bit different. And when you see that, that is a risk, or that is an indication that your brain is at risk for seizures. You can also see seizures that we'll look at, and then sometimes you see an abnormal background. Just the resting state of the different looks a little bit different. That isn't necessarily associated with seizure, but it does make you take a second look that maybe we didn't quite see the risk factors for seizure and we want to do a longer EEG if we see that abnormality in the background. Okay, so this is a completely normal EEG. Um, you can see there's grouping. So there's this group from here, these first 4 lines, these second 4 lines, these third group of 4 lines, and then the fourth group of lines. Each of these grouping of 4 represents a line. The odd numbers are on the left, the even numbers are on the right. So we have lines from here to here, from the front, F, to the back, O is occipital. And then here, those are those lines, like I said, from the front, F, to the back occipital, but going around that temporal lobe. Now so when you look at this, you see the top of each 4 lines, there's an abnormality. It kind of goes down, there's a dip. And that is actually an eye blink. So that is when your eyes close, your eyeball actually rolls backwards. It's called a Bell's phenomenon. And that changes electricity because the back of your eye is positive. So you can see what an eye blink looks like. So this is a completely normal EEG. The patient is doing some blinking. These green lines represent about 1 second. This red line is where I'm at that point in the EEG. If I wanted to see a movement or something that was happening in a video EEG, that's where I could pull up the video. I could pull it up right at this moment and I could time lock the video to the EEG to see if something is a seizure. This is completely normal. And what I like to say about the brain is if it's a little bit chaotic, like there's just no rhyme or reason or pattern it really looks like that you can pick out on, that is a good EEG. Down here, the red line on here, the third line from the bottom, this is an EKG. So it's a test of the heart rhythm. We have 1 line for the heart rhythm. And you can see how your heartbeat is very, very regular, which is good. If your brain looks regular like that, then I get more worried it's a seizure. The brain loves this little chaos because it's just constant little measurements of electricity. So in our EEG, right here, the best place to see them is right here. Do you see how there's these kind of sharp up and down lines? They kind of stand out that there's just this vertical line in the EEG right here. That is an interictal epileptiform discharge. So that is a little point where the electricity is different, and that's what we call a focal discharge. It's focal because it's only in this grouping of lines. And where I figure that out is then I go back and I look at where these letters are. So here, I know that it's in between the central, like right here, and it's an odd number, so it's on the left. So I know these discharges right here on the left side of my brain, right about in the central region. So I know that right here in the brain, there is some abnormal electricity. Sometimes, oh, I didn't know that was animated. That is where the discharges are. So sometimes your discharges are generalized. So generalized just means it affects all of the brain completely at once. So this is a generalized discharge. It's all parts of the brain all at once. Focal is not better or worse than generalized. Generalized isn't better or worse than focal. They're just different. A generalized seizure is probably more likely to have like an acute loss of your responsiveness. You're probably going to have more generalized shaking or generalized stiffening over the whole brain at once. Whereas a focal is going to show you that activity from the brain where it was stimulated. But the prognosis isn't different, whether it's a generalized or a focal seizure. So this is a seizure. So this is a generalized seizure. And I pulled this from an EEG that I was doing back in 2013. And so you can see where it starts. The brain kind of this is normal brain. I had kind of made it look a little bit like flatter so I could see the seizure. But you can see there's this abrupt change where this activity becomes very regular. So it looks like a very regular pattern, which is a seizure until proven otherwise. A seizure on EEG. So if I'm looking at an EEG, I would call something a seizure if these discharges lasted at least 10 minutes. And I didn't copy and paste the whole thing, but this did last 10 seconds. I apologize, 10 seconds. So if there's a discharge that lasts 10 seconds, that qualifies as a seizure. Some seizures don't show up on the body. They're only in the electricity of the brain. So that would be what we call an electrographic seizure, an EEG only seizure. Or it can be shorter than 10 seconds if it causes a change in the body. So this pattern to me looks like a classic staring type seizure, what they used to call petit mal. Now we call absence. And so I would guess that right when this red line started, the patient stopped responding and was probably staring. And then when that discharge stopped, they returned to their regular activity. So you can have EEG only seizures that don't change the brain at all. You can have electroclinical seizures where the EEG changes and you have clinical symptoms of that seizure. And then you can have, well, no, you can have clinical seizures because the EEG isn't perfect, but we won't go down that road because that's an epilepsy tangent. Okay, so getting to this population specifically, 30 to before, so this is quoted from the gene reviews. So kind of the summary in gene reviews from the NIH of the Pike3 mutations, 30 to 40 kids have epilepsy. I would say I put a little asterisk next to that because there are other things that can cause a seizure in kids with Pike3 mutations that would not necessarily be epilepsy. So we were chatting before the lectures started that you guys had a lecture on hypoglycemia. Hypoglycemia, if your sugar's too low, that could be a seizure. We call that provoked. The low sugar caused the seizure. And if you prevent the low sugar, then you prevent seizures. So you wouldn't start medicine there. If you have a bleeding disorder or abnormal vessels that are at risk for bleeding or a risk of blood clots, or certain malformations of the blood vessels or masses or tumors, those can be annoying to the brain and those can cause seizures. Those are, again, provoked seizures, but if they continue to happen, we often treat them with medicines. And if you can't remove the risk factor, then we treat them with medicines and we would call that epilepsy. Anytime you can remove the risk factor, we call that provoked seizure and we don't call it epilepsy. Okay. No joke. I absolutely love it. But the main epilepsy group of them around the world, especially in pediatric epilepsy, is called the International League Against Epilepsy, which I think is the greatest name out of any advocacy group. Your guys' is great too, but I mean, the League Against Epilepsy is pretty cool. And unfortunately for neurologists, they change the name of seizures about every 5 to 6 years. The same seizure has like a billion different names. So this is kind of just an overview. They make it easier every time they do it, but it's not easier if you remember the old names. Everyone you see will also remember the old names. So I'm going to talk a little bit about those too. But broadly, seizures are characterized into 3 different areas. So those that are starting in one part of the brain, seizures that are starting in the whole brain all at once, and then those seizures that we're just not really sure where they started. So in a focal seizure, you can be fully aware. So you could have a focal seizure in this part of your brain, and you could have twitching in your hand. And it's such a small area of the brain that I could still be talking and I could be aware or I could be thinking. Sometimes you have a focal seizure and kids will look a little out of it. They're not really responding, but they're able to pick things up or they're picking things off their clothes or they're able to walk around. Those are focal seizures. And they have like an impaired awareness, but you can't always tell. I had a patient who was just kept running into walls. She was just suddenly clumsier than usual. And that ended up being seizure because part of the brain was having that abnormal electricity and wasn't cooperating with the rest of the brain. You can have non-motor seizures. So when we say motor, we mean movement. So you can have movement seizures, or you can have non-movement seizures. So these used to be called petit mal. Actually, these are focal. So these would just be called, you know, the inability to talk, or a smell or a taste, or just kind of non-really responsive are non-motor. So those are seizures that you're not moving. Generalized seizures um, have impaired awareness. So that's a really great way we can tell if a seizure is from abnormal electricity in the brain or is something else. So if you have both sides of your brain are involved in a seizure, so if you have both arms that are stiff and shaking or jerking, that means that this arm is shaking from a seizure over here, this arm is shaking from seizure activity here. So both halves of your brain are affected. That will impair consciousness. Focal seizures, you may or may not be responsive. A generalized seizure, you would have impaired consciousness. These can be called convulsive seizures. These can be called GTCs. They're now called motor or non-motor. Motor seizures, so movement. The traditional name, one of the original names, is a grand mal. We also call them GTCs for a generalized tonic-clonic seizure. And what that means is tonic just means very stiff, and clonic means small movement. And so often seizures have a stiffening and a jerking, and it looks like they're very stiff and they're like doing these little movements. That would be a GTC, a generalized tonic-clonic seizure. Or there's other movements you can make. You can have just a tonic seizure where you're very, very stiff and you can't see if I put my hand in front of my face, but you're very, very stiff, or you get very, very tight. The muscles get very, very tight and they don't respond, and then their body relaxes. And then the other non-motor generalized seizure is an absence seizure. Absence was also called petit mal or staring seizures. There are other generalized onset seizures that are seen in, they're very rare. They're called infantile spasms. Those are generalized seizures with like a small little body jerk and stiffening that occur in clusters. And then in that third category of unknown onset, you can have, sometimes you don't know where the seizure is coming from. Sometimes, your electrodes are on top of your head in most cases, and it needs about 8 to 10 centimeters of brain kind of involved for it to pick up on the electricity. So it might be a very, very small area, or it might be deep. You might be having a seizure deeper in the brain that the EEG is just not able to pick up on. So I do have lots of patients who have an abnormal, or they definitely have seizures, but I haven't been able to figure out where they're from. And in that case, we do other specialized testing that we'll talk about. Okay. So actually, I'll talk about it's in a previous slide. So what do you do if you definitely have a seizure and you can't tell where it's coming from your MRI, you can't tell where it's coming from your EEG? So there's other specialized tests. So there are PET scans where we give you a contrast. So it's basically radio labeled glucose. And so when your brain's having a seizure, your brain takes up more glucose, needs more sugar and energy in that area. So when we do these, they're called specs. We have them come in to the hospital. We either have them stay for a few days. A lot of times we take them off their medications to try to have that seizure while you're in the hospital. And they stare at the EEG. So the very second a seizure starts on EEG, they push the dye. And the dye is that radio labeled glucose or sugar. And so all the sugar concentrates in the area where the seizure started. So you can tell where the seizure starts by the area that's taking up the most sugar, and with that dye kind of going along with it. Sometimes you'll do a dye study while the patient's seizing, and then you'll do a dye study when the patient's definitely not seizing. And then you combine those images, and we call what you call subtraction, to kind of figure out what areas are involved to see if there's multiple. The other thing we do is something called a MAG, which I think is very cool. They're They're rare. There's not every center has one. We have one down the hall. Actually, it was causing a ringing, which is blessedly stopped in this room. The MEG combines the EEG, so you're looking at the electricity from the electrodes, and an MRI. And it really draws a picture of how the electricity is moving in your brain and can tell you where the electricity moves and where it's abnormal. And then the last part is that you sometimes we do a surgery, and we take these tiny little electrodes that look like hairs, really tiny, tiny, tiny little needles, and they insert them actually right into the brain. And that's called the stereotactic EEG. And those EEG leads read the electricity from deeper in the brain to tell exactly where those seizures are coming from. So there's a lot of things we can do to figure out where the seizures are coming from. But if you can't, it doesn't, you just treat them with more generalized medications. Ooh, off, really off. Hold on. Okay. Um, so what do we do? We have seizures. We've given you lots of pictures and overwhelming information. And the good news, there's a lot of things that we can do for seizures. So when it comes to medication, there's daily medications. So medications like Keppra or Zonisamide or Depakote. There's medications that we give every day to prevent seizures from happening. I think of these like water. So if you have, let's say, a campfire, you might pour the water on the campfire to put the seizure out, and then it doesn't restart. Or you might pour the water around the campfire to prevent the seizure from spreading, because it's okay to have an abnormal EEG. We don't necessarily treat the EEG, we treat to prevent seizures. And so either you're putting the seizures out directly with that medication, or you're kind of preventing those discharges from spreading to other areas. You also have emergency medications. So these are the two types of dispensers that we use for emergency medications. This one here on the left, this is called Diastat. So this is rectal Valium. We call it a rectal gel, but it's actually a little bit thinner. I think it's more like corn syrup-ish, or somewhere between like a honey and a pudding thickness for those of you who use thickener. This Diastat is designed for parents. As a physician, we will write a very specific prescription for what dose we want. On your Diastat, there should be a green sticker that's visible once the pharmacist connects it with the right dose, and it'll say ready. There's also a window right on the Diastat that tells you what dose is going to be prescribed, because there's more than the dose sometimes in these syringes. They're programmable. It's a one-time use, but the pharmacist will lock it in to give the exact amount of medicine based on your child's weight or age and age. And so you always want to check to make sure that this Diastat is prescribed or is locked into the right way with that ready tab and the right dose in the window. We use Diastat, it's given rectally, and you can see that there is a probe and then there's a guard. And that guard is there to prevent you from going too far. It's a plastic guard. It's very rounded and blunt, so you're not going to hurt the child. Although if they're not seizing and you try to give them a rectal medication, they probably will fight you. And then you know they're not seizing. This is Valium, so it's a medication. The biggest side effect is it'll make you sleepy. And so you just give that rectal medication after whatever instructions your physician gives you. A classic one is either 5 minutes or a cluster of 3 short seizures. But you and your physician should talk about what are the criteria when you would use an emergency medicine. We use Diastat typically for kids under the age of 2. Because over the age of 2 is this device over here. So this one says Valtoco, but there's also medication called Nasalam. And so these are either nasal, so you just squirt it in the nose like a Flonase bottle, like a little Flonase dose. These are either midazolam or diazepam, Valium or Versed. And they're similar to the Diastat. It's a benzodiazepine, and it's meant to stop the seizure acutely. These also can cause a fatigue, and kids get very sleepy after they have them. If you get too much, you could be so sleepy that your breathing is affected. You're breathing slower or shallower. And that's why the first time the first time a family uses an emergency medicine at home, we often recommend that they call emergency services to come get checked out, make sure they're looking okay. A lot of times emergency services will say like EMS or 911, won't transport you to the hospital if you look okay. Although I always warn my patients, just check with your insurance because sometimes they won't pay for the ambulance unless you go to the ER and you still get a bill. Um, there are other types of emergency medicine. Sometimes there's like little dissolving tabs that we'll use. I will use dissolving tabs because you can tuck it in the side of the mouth next to the teeth. I try not to use liquid or tabs unless there's a G tube because if you're having a seizure, you don't want to put a lot in the mouth. Basic seizure safety is if someone's having a seizure, you don't put anything in the mouth. The tongue is actually a large muscle that's attached all the way down through your neck. So you cannot swallow your tongue. But if you have a seizure and you clench your teeth, you can bite things off like spoons or body parts. And so that becomes a choking hazard. So don't put anything in the mouth. If anything, you can just gently tug at the side of the cheek to let the spit pool out. One of the things that looks the scariest about a seizure is that you don't swallow your spit. So you have this pooling of secretions. It gets very foamy. It looks very white. That idea of foaming at the mouth probably came from descriptions of seizures. And sometimes your child might even look a little bit red or blue or purple. Oh, I have something in the chat. Is that for me? Oh, not for me. Um, that is because the skin around the mouth and the eyes is very thin, and your body is very smart. And so when there's a seizure, your body is moving all the blood to place, not all the blood, a lot of the blood, the oxygenated blood, to your brain and your heart to keep things going. And so although your child might look blue or purple or dusky, they are breathing. They're just breathing in a very shallow way. And so the best thing you can do for that is to give them an emergency medicine to rescue their seizure and to stop their seizure. And it might sound weird because I'm telling you that they're breathing very shallow, and so they're not getting, there's parts of their body that aren't getting the same oxygen as their brain and their heart. And then I tell you to give a medicine that makes them more sleepy, but it's safe as long as you give the right dose. And so that's why it's good to talk to your physician. You will often see in the hospital people checking the pupils or putting on oxygen, which are useless. Not useless. It's not the first thing I would do. If I was there, what I would do is gently adjust to make sure that that you weren't obstructing. So sometimes kids, their neck will come down. So you want to just gently lift up the neck, or actually the best thing to do is roll them on their side. That way that airway stays open. You roll them on their side like they're curled up in the fetal position. Make sure they're not going to hit anything with tables or chairs. If you don't have an emergency medicine, you would call 911. And when they get there, they'll give them a medicine, usually in the nose now, or sometimes a shot. Seizures look very scary. I see seizures every day. I've seen hundreds, thousands, tons of seizures. And they still, my heart will pound. But short seizures don't damage the brain. They don't change the brain. And that's why if your child's had a seizure, it's important to have a rescue medication and to keep it on you. You want to make sure that the rescue medication doesn't stay anywhere that your child can't. So no hot cars, no cold cars, but you can keep it in your bag as long as you're keeping it like in a, normal temperature place. There's other things that we use for epilepsy. It's sometimes not the first line, but occasionally it is. There's devices that we use, something called a VNS, is a tiny little disc that a surgical procedure puts underneath the skin. And then the wire wraps around the nerve that goes in the neck, and it gives a electrical pulse. It can be a really great thing. I like VNS a lot because it becomes more effective. Like over the first 3 years, it becomes more and more effective. They're starting to use it for depression treatment, so it doesn't have mood side effects. And it gives you a constant pulse of electricity on that vagus nerve, but then you also have a magnet that you can swipe. So there's something you can do to stop seizures. But it is a procedure, so it's not right for everybody. If you have bad sleep apnea or bad snoring, you want to get that checked out because a VNS can make sleep apnea worse. And like I said, it is a procedure. Other devices, a newer one is something called an RNS. So an RNS is also kind of like a little disc. It's a big surgery because they put it right under the skin in the bone of the head. And the RNS leads, instead of going around a nerve, actually go right into the brain. So we talked earlier about that stereotactic EEG where it can read deep in the brain. The RNS is a device where the leads stay in the brain and it reads like an EEG and then responds to what the device is programmed to. So we can give little pulses to stop the seizures when they come. Um, there are dietary options for epilepsy. So the ketogenic diet is a great one. If you look at historical texts, you can talk about like starving the demons out of them. It was probably the ketogenic diet. So it's a very strict ketogenic diet. You can't take breaks. You're very, very strict. If you have a eater who likes food or likes candy or likes birthday cake, it's not a great diet because it's really hard to follow. Like a typical food, I was looking at a menu, would be like a hot dog with oil, maybe some butter. Strangely, like toddlers love butter, which is great for them. Or like some macadamia nuts, which parents have pointed out is probably the most expensive nut possible. So there's a lot of other options. If your child is G-tube fed, there's ketogenic diet formula. And so it can be a good option. I also have patients that do the modified Atkins, so not quite as extreme, but try to keep that low glycemic index diet. And then there are surgery, and then there's clinical trials. So there is a lot to do. I think it can be really overwhelming, and epilepsy can be really scary, but there are a lot of treatments and a lot of advancements and a lot of things we can do to have a really great efficacy and great quality of life and safety. And, once you are in a stable seizure place, kids can do really anything. I like to joke with my patients that, they're not going to get out of, listening to their parents or doing chores or doing things like that because, and parents have to, put them in timeout and punish them because they're normal kids. Once we get some medicines on board, and even before that, they're still normal kids. We just have to kind of watch for some events. Yes, so that's my last slide. Thank you for listening. Hopefully it was helpful. I would love to have any questions or thoughts or anything that you want to share.
Thank you, Jenna, for that. It looks like
Uh-huh.
Joanna has a question for you. She says, hi, my daughter is 11, has had focal seizures since 2020. She's currently on a combination of clobazam after weaning off Keppra and Triliptal, but she's having frequent breakthroughs. She's also gained a lot of weight since starting the clobazam. What's the next medication you'd try? Our epileptologist has mentioned zonisamide.
Yeah. So really epilepsy is it's almost as a physician, I love treating it because it takes from all three areas to decide what your next med is. So medications can be really good for focal, really good for generalized, or both. And it sounds like the medicines you're on are really good for both. Um, it depends on what your EEG looks like. Sometimes there's characteristic things with your EEG. It also depends on what other medical conditions. We have to think about what side effects do we have from medications. Zonisamide is a really great medication. I like it a lot. It can do focal seizures or generalized seizures. You can give it once or twice a day. In general, anything you put in your body can cause a rash or can cause upset stomach. Those are the most common things, but in general, it tends to be a really well tolerated medication. Very, very, very rarely do I have patients. Sometimes it can cause some mood changes, but not like Keppra. Keppra is pretty classic for causing what we like to call the Keppra crazies. Um, but it really is like a very personalized discussion with your doctor about what is important, what side effects are you more at risk for, what seizures are you more at risk for, and what medications might work and might not work for you. So this is me hedging and not answering, but saying that it seems like it's a good medication that I use frequently.
Okay, thank you. She also said, more of a curiosity question. When my daughter has had a few seizure episodes in a short time, she gets very dark under the eyes. Sometimes it's the only way that we know she's had a lot of seizure activity that day. What could cause this?
More than likely, it's more like fatigue. So after a seizure, you have this, what we call post-ictal. So ictal means seizure, post-ictal means that after phase. Everybody has different post-ictal phases, but it's probably a deep level of fatigue. A lot of children, that's one of the more common things post-ictal that you see is fatigue. And if she's had a lot of seizures, she's really just exhausting her body. And I think that she's probably, whether, I don't remember, I think you said 11. Sometimes kids don't look tired. Sometimes they don't act tired. Sometimes they act the exact opposite of when they're tired. And so it's not infrequent that I see like dark circles under the eyes as one of the more frequent things, especially if they have really tiny or focal seizures that are just about treated. Sometimes those seizures can be so small and so short that just by watching them, you can't even tell they're having seizures and you have to get an EEG to confirm.
Okay. Sherry says, my son's seizures are always at different times and places, so tricky to predict. They also began at 14, just would like thought.
Yeah. Oh, sorry, what was the last part?
And oh, also have been always told that he has strange white matter. What does that mean?
Oh, good question. Okay. Um, so yeah, so some people have predictable seizures. So some seizures occur at night, some kids have seizures that kind of occur in that transition, and then some people you can't predict. Sometimes treating seizures makes it a little harder to predict. And the last part of the question. So your brain has two types of cells, or types of brain types. You have your white matter and your gray matter. So the gray matter is on the very outside coating. And then the inside is the white matter. And it's actually where your brain cells are sending all of their long strings to get to each other. And so it's made up of myelin, the covering on those. So that's why it looks a little whiter. Seizures tend to come from the white matter. And then, so if the white matter is abnormal, it might mean that your white matter, there's too much white matter. It might mean that there's not enough white matter. It might mean that there's area where the white matter is a little bit worn or there's less of it in that area. Sometimes it looks bright on an MRI because it has that area of gliosis, like we talked about, that kind of medical scarring. So there's any number of things that can cause white matter to look differently. Sometimes you're born with too little, sometimes you're born with enough, but then it kind of fades, called demyelination. And it's commonly seen when you have epilepsy because seizures tend to occur in the white matter. I hope I answered all of the things there.
Yes, I believe that you
Okay.
did. Brittany said, I got on late, so may have missed it. Are there specific MCAP phenotypes slash findings that increase seizure risk?
Yeah, so anytime you have an abnormal MRI, and so the structure of the brain looks different, whether it's the focal cortical dysplasia or the here I'll share again. So we kind of talked about the different types of the brain changes. So hemimegalencephaly is a really commonly associated seizure type where half of the brain is bigger because those cells are growing in an abnormal or different way. The focal cortical dysplasia is a really common one to have seizures that come from one part of the brain, a focal, because there's just like in this picture, you can see this little bright triangle where that the cells in that area are different. And then megalencephaly, more commonly with MCAP, you see the brain gets bigger either from the cells growing in a different way or from the center, the spaces in the center of the brain being bigger, so more fluid in the center of the brain. And so if you have an abnormal MRI, you're going to be more likely to have seizures. And I was trying to figure out, well, I was looking up literature, but it makes sense to me that there isn't one classic seizure type that's associated with pike 3 mutations or PROS or MCAP because it depends on what's going on in the brain. So there's different things that can happen uh, with the brain, and whatever's going on with the brain is going to drive what kind of seizures you have, whether it's a focal shaking, whether it's a focal unaware or staring type, or whether it's like a tonic or tight seizure. So I hope that helps to answer your question.
Yeah. I think we have time for one more. Do absent seizures also cause post-ictal episodes?
Great question. So not typically. So absence seizures are typically often you notice that they're having them because when they come out of it, they immediately return back to their activity and they're like, why are you staring at me? Why is everyone looking at me? You know, they weren't responding for 2 minutes, but they come back, but they time jump. And so absence seizures do not always have a post-ictal phase. Now, if you're having a lot of them and you're missing a lot and you're missing a lot of like time jumping points in time. Some of my younger kids, like the 5 and 6 year olds, like I was seeing a patient who was having increasing agitation because she was missing parts of time and she was actually having a lot of anxiety because the teacher would ask her questions about the story and she didn't know the answer because she didn't hear the story. So you can have different things coming out, but that like deep kind of like sleepiness, that sleepiness that is like different than regular sleep, that really, really deep sleep, or agitation or even psychosis, those kind of postictal things are not typical after absence seizures. However, what I will say though is that what looks like staring might not be a typical absence seizure. And it might be a focal seizure that then spreads to what looks like an absence seizure. It might be a generalized seizure that just has less movement. So it's possible to look like you're having an absence seizure and have a postictal phase, but then it wouldn't kind of technically be the absence. And this is why epileptologists are nerdy, because we really geek out over names.
Jenna, how's your time? Do you have time to go
I
over a
got lots
little
of
bit?
time. Yeah, I have a meeting at 1:30, so I'll stay for like hours to avoid that.
I have if you don't mind, I have a question just that will help me with advocacy because a question comes up. We all are at risk for seizures. We know this as soon as we get the diagnosis.
Yeah.
And so sometimes we have a family, come to one of us or come to our group and they think their child has had a seizure and they don't know what to do. They don't know if it's an emergency. It's Sunday night or worse, Friday night.
Mhm.
What kind of guidance could you give about when it's an emergency and what families should do if they think they've seen their first seizure?
Great question. So a seizure emergency is if a seizure is long. So if it's your first, let's say first time seizure, if you're having a seizure and by the time you run to get the phone, and honestly, if it's your first time seizure, I would probably call 911 and go to the ER for a first time seizure. If it's a clear, generalized shaking or otherwise not responsive seizure, even if it's a minute or two, if you live close and you can scoop and go to the ER, we never recommend it, but call 911, but I would get seen for that. If it's, let's say, some of these seizures that look a little different, like you have like a little twitching of the face because you have, this part of the brain affected, and you keep seeing these twitches of the face, and you're not sure if it's a seizure, then I would say if they're just like a few seconds and you're not sure, it's okay to start with your physician, and your physician can send you to neurology. If you can self-refer, you can always self-refer to neurology, although you'll want your physician to tell them what you're looking for. So you can start with an MRI or an EEG right with that appointment. If there's ever a concern that your breathing is affected or they're not swallowing spit or they're not responding to you, I would call 911. I would err on the side of going, either take him to the ER or calling 911 because they can arrive with materials and equipment that can help keep your child safe. It's never wrong. If you're worried, you know your kids. If your gut is like freaked out, call 911. I would say if you're kind of like not really sure, videos are incredibly helpful. So, you have your smartphone on you all the time. There's apps with that will help you record like seizure instances, and sometimes will like make it easy to flip on a video in a light. Taking a video for your physician is incredibly helpful. We can often say, definitely not a seizure. That's a breath holding spell. That's something kids do all the time, or that's a little, you know, shaking, just shuddering spell that babies do all the time. So videos can be incredibly, incredibly helpful. And when you've already seen neurology, we love to see videos because it can help us tell like what we saw in the EEG or not. We don't treat, so it's hard because when you get a diagnosis and you might get an MRI and you're like, well, now I know I'm at risk for seizures. We don't start medications right away. So if I saw someone who'd never had a seizure, if their MRI and EEG was abnormal, I might, but I might not. And it depends on age. If they're a teenager and they're, a little more at risk, I might start a medication. But if they're a toddler and they're always being viewed and they're smaller and just, I might not. And so that's always going to be a really in-depth conversation with your doctor. As a mom, I would say it's never wrong to ask if you can have an emergency medicine. I mean, I think if you've had a first time seizure when they call from when you call from the ER, I just say send them home with Diastat or the nasal spray, as long as your insurance can cover it or you have backup insurance. It's never wrong to have that emergency med. Even if you don't feel comfortable using it, you can call emergency services and hand it to them and say, here, give this. The first policeman or fireman that shows up, here's their medicine. I don't know what to do with it. Does that kind of answer the question? Is there more? Because yeah, I can keep
No,
going.
I think it's very helpful. I mean, it's even helpful to know that even for you, it's not like a cut and dry question.
No.
So, because sometimes, you'll have somebody and they'll say the closest ER is 3 hours away. So it can be a hard judgment call. So, no, your answer is helpful, I think.
One thing that I always recommend going into that like hospital, you can go to a small hospital and they'll usually call, like I'm in Michigan. And so I get calls from like the UP, Northern Michigan. I get calls from them all the time to say, this is what we're seeing and we help manage that. The other thing I always recommend, this is a random fun fact, but I like to recommend when you're traveling, if you're driving, kind of know, like if you're driving from Michigan to Florida, you're going down 75, know your big children's hospitals. So know, you're going through Columbus, I don't know where you're driving, but you go through Cincinnati, you go through, these big children's hospital, know where you can go if you need to be seen. If it's not an emergency, like you can wait 30 minutes, 45 minutes and well, okay, then I'm definitely going to go to Atlanta Children's. I'm going to go to Arnold Palmer in Orlando. I'm going to know where your big places are because they're going to be more likely to either know your mutation or they're going to know enough to know where to find the information they need for your mutation. Okay. There's a great question about puberty. Yes, in many cases, puberty does increase the risk of seizures. So we'll have kids that are really well controlled. They start to go through puberty and those hormones and it wreaks havoc. It is the least favorite part of child development in my life because it can really be really difficult. It can take a while. Estrogen in general can be pro-seizure, whereas progesterone is not as pro-seizure. So a lot of times we'll even go to progesterone-only type of reproductive medications. But yes, puberty can definitely increase the risk of seizures. Either if you have epilepsy, it can provoke them. And then there are patients who start having seizures in the teenage years. The question is how long after an EEG does activity show from a seizure? So you might have 10 seconds of an abnormal EEG. You might have a permanent change on your EEG or a semi-permanent change on your EEG after a seizure. So a 30-minute EEG, if it's positive, if I see discharges or I see a seizure, incredibly helpful. It tells me that that was a seizure. It tells me that there's a high risk of seizure and I'm more likely to treat. A negative EEG is not always as reassuring. A negative EEG, something that says your EEG is completely normal, does not rule out seizure or epilepsy. And if you're convinced that it is a seizure or you have a high suspicion, it always warrants further workup. The EEG itself, if you capture a seizure, when you see a seizure on EEG, if it's like an absence or petit mal, the EEG normalizes like within a second or two. Other seizures, like bigger generalized seizures, sometimes have more of a background change for a little bit after the seizure. And then the other question is, are there mostly abnormal MRIs in patients with PROS and epilepsy? I am going to
If
be,
I could maybe,
Okay.
a lot of people with PROS don't have brain involvement.
oh, thank you. Yes, I'm
Or
thinking
they
more
may
just,
even have a little bit of an increased head circumference, but
Mhm.
they don't have any neurological symptoms. Now, I don't know what this person's situation is, but because they used the term PROS and not MCAP, I just wanted to be clear that some people really don't have brain involvement.
Good. I was actually just going to say I am not an expert in PROS, so I can't say like looking at the Pike 3 related syndromes, I can't say that predicts epilepsy. If you had a normal MRI and a normal EEG, I wouldn't say you're necessarily more involved for epilepsy, but if you have an abnormal MRI, then you definitely are, even whether you have PROS or not. So I hope that helps your question, but I think it was probably more of a hedge. And I apologize. I might be like using the terminology just a little bit abnormally, so I apologize if I'm more confusing on those.
Thank you. It looks like that was all the questions we had, Jena. I really appreciate you spending the time to do this with us. It was awesome. That was a great talk.
Thank you. Well, you're very welcome. Yeah, if you ever need anything, let me know. I'm happy to help. And yeah, you're very, very welcome. I
Sounds
enjoyed it.
good.
I love talking.
Yeah, it seems like we have a lot of questions, and so maybe as a community, we'll talk a little bit and see if we want to bring you back for something more specific.
Yeah.
So
Anytime.
thank
Stump
you.
the
We
chump.
really appreciate this.
You
Yes.
honestly, I can't give medical advice. I will be very careful not to because epilepsy is such a very specific thing. But if there's general questions and they come up, you're more than welcome to send an email. I think Shannon, I think you both have my email, so I'm more than happy to share knowledge or articles or whatever I can.
Great, thank you.
Thank you so much. And thanks
You're
to
welcome.
everyone for attending. Have a great rest of your day.
You too.
Thank you. Bye.
Bye.